Welcome everyone. Today I'm going to present to you my progress on my PhD thesis, which is using personalized treatment to improve early resuscitation in septic patients. My name is Gábor Nagy. I'm working at the Semmelweis University's Department of Emergency Medicine. I'm an advanced critical practitioner. I envision a healthcare system in which each patient receives the care that's best for them. My mission is to eliminate non-evidence-based data to improve survival in sepsis and septic shock. In the service of better patient care and outcome, I have two ongoing projects. Both of them started last fall. Let's move on to my first project, which is comparing the safety and effectiveness of personalized versus fixed volume fluid resuscitation in septic patients. Sepsis causes the death of more than 10 million people every year. Fluid resuscitation is an immediate priority and plays a fundamental role in the treatment. Current guideline recommends a fixed volume of fluid resuscitation. This approach doesn't take into consideration takes into consideration only a single factor, which is the patient weight. That means that this approach didn't pay attention to any other actual or previous condition. But we all know that in medicine, one size doesn't fit all. What do we know? Fluid resuscitation is a double-edged sword. It can save lives by restoring hypoperfusion, increases cardiac output, consequently oxygen transport to tissues. But numerous studies have reported that the harmful effect of this procedure, of the inappropriate fluid resuscitation. For example, fluid accumulation syndrome, which can seriously impair the function of the vital organs, especially the kidneys and the heart. Resuscitating based on personal physiological needs is widely accepted, but the evidence of its efficacy is still limited. In contrast, our aim is to investigate the effectiveness and safety of personalized fluid resuscitation compared to fixed volume or other non-personalized approaches. Our clinical question sounds like, is personalized fluid resuscitation safer and more effective compared to fixed volume fluid strategy? To answer this question, we use the PICO framework. We investigating septic patients. In the intervention arm, patients will receive fluid on a personalized way based on their fluid responsiveness, and in the control group, a fixed amount of fluid is received. Our main outcome will be the 30-day mortality, and the secondary ones are organ support 3 days, hospital length of stay or ICU length of stay, and SOFA score changes. We hypothesize that personalized therapy is associated with better outcomes compared to guideline-recommended fixed-volume strategy in sepsis. We conducted a systematic search with a two-domain search key. The first domain refers to the population, and the second one covers the intervention. After the systematic search, we found more than 9,000 articles, and after the selection procedure, we ended up with 11 eligible articles for our meta-analysis. We have two finished analyses and 6 ongoing analyses. Let's talk about our main outcome, which is the 30-day mortality. In critical care, this is the most important and the most hard outcome because we want our patient to survive. This outcome was reported in 11 articles. All of them were RCTs. More than 1,000 patients' data were investigated with 11% heterogeneity, which is a relatively low heterogeneity. And two different methods were compared to each other, the personalized way and the fixed volume fluid resuscitation. And as you see, the pooled odds ratio is 0.62, which means that personalized fluid resuscitation reduces the 30-day mortality nearly by 40% compared to the conventional, guideline-recommended method. This is a clinically significant result and statistically significant as well because the confidence interval doesn't fit the null effect line. So it suggests that personalized fluid resuscitation should be prioritized over the fixed volume fluid resuscitation method. One of our secondary outcome is the length of hospital stay in days. It was reported in 5 RCTs, more than 400 patients data was evaluated. This outcome shows not a significantly or clinically different value between the two groups. If you see, if you look at the forest plot, it means that in the personalized resuscitation group, minus 0.2 days less the hospital stay is. But I have to highlight this outcome has strong limitations because because the length of stay was reported only for the whole population, not for the survivors only. So in this case, hence it is difficult to draw any exact conclusion from this result. Our study has some strengths and some limitations. Its strength is only RCTs were included, and this is the first meta-analysis indicating that personalized treatment has potential benefits in septic patients, and the limitations are the moderate and the high heterogeneity could be observed, and different techniques were used for assessment in the intervention groups. Our preliminary conclusion is that personalized fluid management may improve survival as compared to conventional treatment. So based on this, the personalized approaches should be facilitated to become standard care, and in the research field, the best way for personalized strategy has to be further studied. As we finish the data extraction, we move on to the risk of bias phase of this project. My second study is investigating the effectiveness and safety of immediate vasopressor initiation in patients admitted to the emergency department with shock. This is going to be a protocol for a randomized controlled trial. Shock leads to hypoperfusion, organ dysfunction, and resulted in a high rate of mortality. Hypotension is an alarming sign for hypoperfusion. It is supported by data from surgery, where it was found that when mean arterial pressure is under 65 mm of mercury, it increases the risk of major adverse cardiac events and acute kidney injury as well. But hypertension also increases the risk of the mortality, as you see depicted. The longer time you spend in shock, with the lowest map, the highest risk you have for mortality. So to avoid all of these, fluids and vasopressors play a pivotal role to avoid these adverse events. Current guidelines recommend fluids as first and vasopressors as secondary treatment, but there are no clear evidences on the time, which is the most crucial part of critical care of the vasopressor initiation. So our aim in this case to investigate the efficacy and safety of immediate vasopressor combined fluid therapy in patients admitted to the emergency department with shock. Our clinical question is, does immediate fluid and vasopressor initiation enhance shock reversal without causing harm in the ED patients? Our population will be patients admitted to the ER with undifferentiated shock. In the intervention arm, patients received fluid therapy and vasopressor therapy simultaneously after their enrollment. And in the comparator group, the patients will be treated firstly with fluids, and if it's necessary and they are proven to be fluid unresponsible, they will be treated with vasopressors as well. Our main outcome will be the rate of persistent shock after 3 hours of resuscitation, and the secondary ones are 30-day mortality, ICU length of stay, and SOFA score changes. Our hypothesis is immediate initiation of vasopressor leads to better outcomes in ED patients with shock, and the clinical implication will be enhanced recovery from shock. So to summarize, I have 2 ongoing projects. The first will be submitted in this fall, and the second one will be submitted next fall. I would like to close my presentation with a quote for Roosevelt: "Believe you can, and you are halfway there." Thank you for your kind attention.
How the personalized treatment was, I mean the method, how was established, and how consistent was in your included papers?
Okay, thank you. First of all, personalized treatment means a tailored treatment which takes into consideration the patient's fluid response. We have some methods or some tools to evaluate this response. Static and dynamic parameters, such as passive leg raising test, the most common and the most easier way to assess the patient's fluid responsiveness, I think, is the ultrasound-guided therapy. Meanwhile, with this tool, you can measure stroke volume changes, IVC diameter changes, and based on these measures and these values, you can make your decision and govern the patient's therapy. So in these articles, in these RTCs, most of the tools was used for assessment is ultrasonography, stroke volume measurement, and IVC measurement, and some of them, I think it was 2 RCTs which uses this method, was the passive leg raising test.
In the 11th study you included in your forest plot, what was the time frame for starting the fluid therapy? Was there any consistency, or was there any heterogeneity in starting the fluid therapy?
In most of the articles, personalized fluid therapy started immediately after enrollment. One of the study, the LANSPA study, reported that in some cases the personalized fluid therapy or the intervention was delayed because of a ridiculous reason, because the emergency physician who did the assessment was busy and wasn't able to get there immediately to the patient. So it is a limitation of this study, but most of the studies, the intervention started immediately after the enrollment of the patient.
Regarding the type of the fluid management, so were these studies you involved in your analysis were coherent regarding the type of fluids, or?
If your question regarding to the fluid therapy and the type of fluid, yes, they all used balanced crystalloids.